Welcome to another edition of You and Your Money. I'm Brian Hirsch, and our subject this evening is healthcare. I believe that the healthcare industry reputation in South Africa is waning. Not a day goes by when complaints aren't made about the reluctance of medical aid companies to adequately pay for major levels of treatment. Their argument about the use of new drugs and the apparent prescriptive nature of their own doctors who seem to rule differently against the patient's doctors on a form of treatment is of concern. At a lower level, I would like to share an experience. For the first time at the end of January, I went to the pharmacy to collect my chronic medication. And I wanted to discuss with the pharmacist what was being debited to medical aid, what I was paying for, and what was coming out of my medical savings account. I was ninth in the queue to be served, and I asked the 8 people in front of me, out of interest, if they understood their medical aid, and each of them told me they did not have a clue. When I received my chronic medication, I had to pay a levy of 375 Rand because according to the pharmacist, my medical aid only pays a certain portion for the chronic drugs approved by them that I'm taking. When I added this to my annual membership increase, my increase was no longer the 8.9% as published, but rather 16.5%. And this is very alarming. And joining me this evening are 2 of my regular healthcare specialists, Stephen Romberg, Executive Director, Sasfin Financial Advisory, who's here to talk about medical aids and their approach, and Dr. Mokgokgonola Malabane, Specialist Gynecologist, Malbarton Hospital, to give some insight to why medical aids are seemingly to overrule what doctors are doing and give some insight to the latest improvements in medical treatment and these costs not being covered by medical aids. Good evening, Stephen. Good evening, Mokgokgonola.
Morning, Brian.
Stephen, I started off by saying no one seems to really understand their medical aid. And maybe I've got it all wrong, but my increases in January, which is the first month of the new medical aid year, together with the cost of increase plus my cost of chronic medication, 16.5%. I'm not alone in experiencing that because I've spoken to people in the last few weeks. Are they experiencing something similar? It appears medical aid seem to have increased their premiums and taken away benefits.
Well, Brian, you're one of many who are saying the same thing. I'm glad that there were only 8 people in front of you. There could have been a hell of a lot more.
Believe me, if there were more, you know me, I wouldn't have hesitated to go up and down the line.
Haven't heard from you yet. But the bottom line is there's no doubt that medical schemes at the end of the year always evaluate really what are they putting out there, what's going to be the increase. And I think if we take a look, the Council for Medical Schemes try and control medical inflation to CPI plus 3%. And the average increase over the last year was between 8 and 9%. CPI running around about 5.5%, 6%. If you take the CPI plus 3, it's pretty much in that ballpark. Yes, we had schemes going up as much as 6.2, schemes going up as much as 13, 14%. But what schemes do is they evaluate what they're paying out and what the members are getting. And at the end of the day, it's a very fine line balancing act. And you made mention of the fact, Brian, that schemes are complaining about the high level of costs, the high level of medication. And I just want to alert the members to the fact that it is actually a case. I understand that we as members, and remember I'm sitting here as a member of a medical scheme, same one as that you're on, and we're feeling that more and more money is coming out of our pocket. Our everyday spend is getting lower on the healthcare side and higher from our own personal costs. But medical schemes have to try and regulate the overall spend to the income that they're coming in. Aging population, increase in costs. And really, they need to try and equate the appropriate and ethical and clinical care to that of the cost. Now, one of the things that medical schemes do at the end of the year is when they increase costs, they might decrease benefits. And we've seen that in a lot of medical schemes. I think it's very important for members at the end of the day to evaluate the medical scheme when they can. Generally, or most medical schemes, allow members to change their plan options at the end of the year. And that is when they bring out the increases. And I think it's very important that members at the end of the day understand what the increase is, understand what the plan, what's happening within the plan, and make choices for their need, their health need, their pocket, their expense need for the following year.
Okay, we're going to talk about that because you say evaluate their medical aid, but how many people can actually evaluate their medical aid? That's where the role of a healthcare broker comes in. Absolutely. But let's come back to that in a moment because I want to now get to Mokgokgonola, and good evening to you once again. I want you to come in from the other side, and this is the concern that medical aid panels are overruling the treatment that specialists are wanting their patients to undergo. And it seems to me that they see the medical aids are ruling from before, not even realizing what is going on with the patient. How would you comment on that, Mokgokgonola?
Brian, you're absolutely right. And I'll back Stephen in his answer in saying that you're one of many people that complain. But the contraction is actually on both sides. You know, it's the contraction in terms of what the practitioners are now getting out of medical aid payments, but certainly from a patient point of view, also, they're seeing an increase in the premiums and a decrease in the value that they're getting from the medical aids. But one of the problems that you clearly pointed out is the fact that decisions are made in a clinical setup where patients go to see a doctor, and the doctor says you need treatment A or B. And the medical aid says, you know, that's not what we're going to fund. We will fund something else. It is exactly the same principle as when a patient could just walk up and see the general practitioner down the road. Sometimes they've got to travel longer distances because they're not what we call the designated service providers. Same story with the hospital. So in essence, what we're saying is that as much as we know that medical aids run a business that has to be profitable, but as consumers and certainly as people that are serving patients, we're getting a sense that even the decisions that we make, even clinical decisions, are suddenly being dictated to by the medical aids.
Well, that's what I want to discuss in the next segment. Stephen, I know you want to come in. We've got to take a short break. You're watching You and Your Money. We're going to be taking calls and emails on 011-280-3899. We'll also be taking emails on brian@summit.co.za. We're talking healthcare this evening. Stay tuned. We'll be back after the break. Welcome back. Our subject this evening is healthcare, and we're dealing with public's lack of understanding of medical aids and also the reluctance to fund new medication and medical techniques. My guests, Stephen Romberg and Dr. Mhlongola Malabane. Our lines are now open and we welcome callers and emails. You can call me on 011-280-3899. You can email me on brian@summit.co.za. I'll take Roger's call first before we come back to that question about panels and doctors. Roger, go ahead with the question, please. Roger, you're on air. We seem to have lost Roger. Okay, we'll carry on. Mhlongola, Stephen wanted to make a comment about panels. I want to finish off with that comment about you recommending treatment A or B and the panel overruling the specialist. How do you feel about that?
Look, it's difficult because one understands why patients have medical aid. You know, because a lot of the people cannot really pay out of pocket. And for me, the biggest costs are often the hospitalization costs. But in response to your question in particular, it really, you feel defeated. You've got the clinical knowledge, you've got the expertise to recommend treatment. And this is not treatment that is gung-ho. This is treatment that has been scientifically proven to work. But in certain instances, that treatment is probably not as let's say not as affordable for the patients, and often the medical aids would opt for a cheaper treatment, or that in a patient that has a particular plan, even though we know that they need that, you know, they'll even disregard what we call prescribed minimum benefits. A patient needs a condition that has to be paid for, but the medical aid says, no, because you're on a lower plan, we're not going to cover that.
Okay, Stephen, you're going to come in a moment, but we've got Roger back and Chris as well. Roger, go ahead with the question, please. Roger, you're on air. Chris, you're on air. We seem to be having a few gremlins creeping into our lines. Are our callers there?
Can you hear me?
Yeah. Please go ahead. Please, would you identify yourself and go ahead with your question?
Sorry, Brian, you're speaking to Chris here.
Hello, Chris. Sorry, I'm not sure what. So we've got a few gremlins on our line this evening. Chris, go ahead with the question.
No problem, Brian. I've just started working. I'm just wondering if I need a medical aid or a hospital plan will suffice. I don't really know the differences between the two.
Okay, super. There is a difference, and I'm going to let Stephen answer that. Thanks for that, Chris. Roger, are you on the line? Okay. Pal, would you go ahead with the question, please? Also gone. Stephen, you wanted to make some comments about the panel of doctors and the question raised by doctors recommend a certain treatment, and the panel's got a different view.
Healthcare is a hugely emotive issue. And we have specialists like we have with us on our panel tonight who obviously understand the client's condition, understand the treatment that is required. But the one thing that medical schemes do put in place is they put panels of doctors to discuss with specialists about the treatment. Because at the end of the day, like I said in the very first part of tonight, is medical schemes need to offer appropriate care at the same time as controlling the increase and controlling the costs. So it's offsetting the one versus the other. I very seldom come across where they said no, they won't pay for whatever the reason is, but it's generally the discussion between the specialist and the medical panel, which is definitely something that if a member feels that they're not getting the best benefits or the best response, I would suggest that in the long run.
Very difficult for members. But let's just take Olivia's question. Olivia, good evening. Would you go ahead with the question?
Hello?
Please go ahead with your question.
Yes, I agree that medical aids have gone up a lot more than just the published increased amount. But furthermore, now that the tax benefits is going to be taken away, has this been factored into the overall cost?
Okay, Stephen, that was the point I raised. That was, and I'm not sure, forgive me, I didn't get your name, but to our caller, she says now that she's got the same situation. Premiums have gone up, benefits reduced. Surely you've got to factor that into the increase. I mean, you can't just say, you know, you talk about between 8 and 13%, but what about the benefits that have been taken away? You've got to factor that into the increase, because that's cost coming out of your pocket.
Absolutely, and that's once again going down to making sure that you select the right plan that suits your need. I also go a step further. Medical schemes today, in order to try and reduce the actual burden on members, and the doctor mentioned it, are using DSPs, designated service providers. So they're producing plans where they're telling members to go to certain hospitals, use certain doctors, and via that they'll be able to discount the rates because they've almost negotiated tariffs with those providers and those doctors. Likewise, I've said it on many times on this show, is members need to start taking ownership and account for what they do. Go to doctors, go to providers, try and negotiate rates, try and use generic medication instead of ethical, and try and lessen the burden or cost that is happening out of your pocket and try and put more into the medical aid. So, Brian, there is no doubt it's across all boards, across all medical aids, where costs are going up, benefits are decreasing, but members need to become more and more educated on what they need.
Okay, let me take Olivia's call. Olivia, I believe we got you back. Good evening. Go ahead with your question.
Good evening. I don't understand PMBs. What I also don't understand is that so many chronic conditions that I take medication for every month are not accepted by my medical aid as chronic and is paid out of my savings account. Could you please explain that to me?
Super, Olivia. Thank you very much. Well, we've got both Chris's question about, he said, what's the difference between a hospital plan and a medical aid? We've got Olivia's question. She talks about not understanding PMBs. When is chronic not chronic? I've asked you that question before. But let's just talk about the education, Stephen. You say members must take control. Members must decide at the end of the year what is the appropriate cover. But it's just so complicated, medical aids, to fully understand what you're buying.
Brian, you know, there are specialists like myself, healthcare intermediaries who are out in the market trying to advise, educate, and assist members in making choices, making the correct choices to make sure that they're joining plans that are suitable and joining schemes that are sustainable. So it's very important that members, and we get paid a regulated amount as per legislation, and it's important that members make use of it. They're not getting discounted rates if they don't, and at the end of the day there are specialists like myself in the market who are advising members on plans to choose. So don't just go. I mean, the one gentleman who phoned who wanted to know the difference between a medical aid and a hospital plan.
Is it the same?
Well, it's not, because a medical aid at the end of the day is offering cover for both in and out of hospital, where at the end of the day our hospital plans really only offering cover for the major costs in hospital. And there are many different types. You know, some hospital plans might have limits in hospital. Some might have unlimited amounts in hospital. What type of cover do they want? The other caller spoke about chronics. Generally, chronics are pulled into a hospital plan. So PMBs, every scheme today has to cover 270 PMB conditions and 25 PMB chronic conditions. So for the caller who's just called in regarding the chronic, her plan that she's on has to cover the 25 prescribed minimum benefit chronic conditions in accordance with a formulary, which is a list of medication prescribed to that condition. And if her chronics fall outside of the 25, well, it's up to the scheme on how they pay it.
So chronic is not always chronic. The fact that you're taking it every month, the terminology chronic doesn't necessarily mean it's chronic.
Definitely. You
may be taking medication on a monthly basis, but it just doesn't fall into that 25 chronic medications.
Absolutely.
Mkhonto, let me ask you this question. Do you think that the medical aid has a responsibility to have a look at drugs the members are using and to say to a member, this particular drug, you could have a generic, and this is what we suggest you have, or do you think it's up to the member to investigate the drugs they're taking, talk to their doctor, and say what medication is there in terms of generic? And then the second part of that, is generic medication the same as the normal prescribed medication?
All right.
Quite a lot to handle.
Look, if I start with the second part, whether generic is the same as the original, there's a concept in medicine called bioavailability. So how much of the pill that you're taking is the active ingredient? You know, and there's often a difference in the bioavailability of a particular drug between generic and original. You know, it's just not just a matter of patency, but it's actually sometimes. And I remember there's a specialist who actually had put that patient on a generic of a particular antidepressant, and you know the patient was just not responding. Now it may be anecdotal, but this is more than just a single case. So what I'm saying is that generics may be saving money, but we need to use generics that we think actually have clinical benefit, because that's the whole point of putting a patient on treatment for, you know, for a start. You know, and then your first question was also...
The first part was,
yeah.
do you think the medical aid, and Stephen can comment on that after the break. I'm going to give Stephen time to think about it. But the question is, what do you think the responsibility is on the medical aid? For example, you taking medication to say to you, Dr. Malabani, I think you can take this other medication, speak to your doctor. Whose responsibility do you think that is?
All right. I mean, you know, I think the medical aid industry, certainly, you know, a lot of them do a lot of research on what treatment is effective. But certainly, I think there is room, you know, for the medical aid, the patient, and the healthcare practitioner to actually sit around the table and say, what is in the best interest of the patient? The patient comes to us because they come from a point of, I'm unwell, and I'd like to know what would work best for me. And so when the doctor recommends, they've actually taken the patient's complaints and the doctor's findings on examination into account to recommend a treatment. That does not mean that one cannot use a generic. And you know, certainly there is room for generics. But information, certainly, I think both the practitioner and the medical aid have the obligation.
Well, we're going to continue with that. Stephen's going to answer it. We're going to take a short break. You're watching You and Your Money. Stay tuned. We're talking healthcare this evening. Welcome back to You and Your Money, and this evening we're talking healthcare. My guests are Dr. Malabani and Mr. Romberg, Stephen Romberg. Our lines are now closed, but we shall continue to answer the emails that have come in. From Simon in Katlehong, he says, although medical aid brokers earn a commission, as I'm an individual member, I get no service. Is it because the commission is insufficient? Stephen, you know, when you spoke about going to a broker, it's all built in. But you know, I think the commission's 50 or 60 rand a month, remember?
Brian, if that.
So, okay, then, so the question, you raised the point about have a medical aid broker, but a medical aid, you know, at that sort of cost, a medical aid broker's really got time to provide individuals with service?
Well, you know, there are brokers that do provide individuals, but I think at the end of the day, the individual also needs to take a look at it as the whole financial planning, and there are a lot of financial planners out there that do, you know, the gist of financial planning, healthcare, etc. So there are, you know, I think it's important that members make use of it, and when I say make use of it, you don't have to speak to a healthcare broker every single day, but when you need to make changes, when you need advice, when you need assistance on plan choices, it's a time to pick up the phone your healthcare broker. And there are brokers there that will phone you and say, this is the situation, these are the changes, this is the communication. So at the end of the day, Simon is paying the exact same rate going directly to a medical scheme as he would be.
But be a bit proactive. Say you call your medical aid
Absolutely.
broker and discuss with the medical aid
Absolutely.
broker. So you've got to be a bit proactive. The same way, I want you to comment on the question about chronic medication or a generic in terms of another
Look, I agree with Dr. Malabani. The bottom line is this, that the medical scheme, the member, and the provider need to come to head and have a chat about the best prescribed medication. And I go back to the schemes all the time about trying to control costs. There are a lot of chronic medication or generic medications that are equivalent, and there are some that aren't. But at the end of the day, you'll find that your medical scheme has a formulary, a list of medication prescribed to conditions, and if you take that medication, they'll cover it. Now, there are many times that the medication is not successful, doesn't work with you, and medical schemes have an appeal process where they will appeal the fact that they might need to go on the ethical drug as opposed to the generic. So members need to be, once again, educated on the rules of the scheme, how it works, which is the best way to get the medication that suits them. And I always say that your provider, your doctor, must communicate with yourselves and the medical scheme to try and get the best and most equitable.
I've got an email from Kim in Northwold. She says, I'm a member of Discovery, but my doctor of 20 years is not a Discovery approved service provider. Surely Discovery realised that some of their member doctors are not on the panel, yet a patient has built up a long-standing relationship of trust, and where the doctor has the patient's medical history. Do Discovery expect me just to pay the additional cost or move to one of the approved service providers? This is partly for you and partly for Stephen, but it is a problem where someone's built up trust with a specialist over years, and they've been having maybe their hearts or a pulmonologist, or even someone who's a physician, and now they're not on the panel. Bit awkward, isn't it?
It is, Brian. It is exactly one of the things that we're talking about, is that from a medical aid's point of view, I think for them it is really just trying to stratify and control costs. But from a user's point of view, if you've built a relationship with a particular practitioner, it's more than just going to the grocery store and buying something. You've built up a reputation. They know your medical history. They know exactly what you've been on. They know what you're allergic to. Of course, it's easier to go to somebody else and let them take your history. But from a patient's point of view, if you've established a relationship with somebody, it's convenient. It's probably just a street across the road. The entire family goes there. So it's from a patient's point of view, it's just easier to stay with the person that you know. But the medical aids, unfortunately, have to make those decisions, or they do make those decisions.
Stephen, why can't they get all the doctors to join? Why can't they get them on the panel?
Well, supply and demand, Brian. It's economics. At the end of the day, we're 15,000 or 12,000 doctors short. We're close on probably 30,000 nurses, 30 to 40,000 nurses short. It's all about supply and demand. They're not enough. They're not enough doctors around. I read a statistic the other day that 22% of our doctors that are trained in Africa are in Canada. Okay, we're spending close on 500,000 rand to train these doctors, and they're moving on. So it comes down to supply and demand. But I just want to go back to the members' email or call. The fact of the matter is, the scheme does not tell them which doctor they have to go to. They can go to any doctor, but they must just understand that at the end of the day, if they're not going to a doctor that's part of the network or DSP, they could have shortfalls.
Well, when choosing a medical scheme, we place our health and well-being in the hands of the healthcare service provider we opt to go with. The question is often asked, where does the money go? Why won't my medical scheme pay my medical bills? Because after all, these companies who administer medical aids are making very good profits. I see the problem in that most members are not aware of what their monthly contributions have been spent on, and also what their monthly contributions entitle them to. There's a groundswell of frustration mounting against medical aids after increases and another round of reduction in benefits. There's hardly a day that goes by that there isn't some irate member taking their complaint to the media. Those that manage medical aid schemes are quick to defend their position and don't fully understand what members go through when they've had some major illnesses and have run out of their savings and medical benefits for the year. The comment that the benefit design of schemes is not in favour of the patient and the Medical Schemes Act should be revised is gathering more momentum. We wait to see whether the National Health Insurance is going to deal with some of these issues. I'd like to thank Stephen and Mkhlokhanola for joining me this evening. Before acting on any advice you may have heard, please consult with either your medical aid broker or directly with your medical aid. Next week we'll be discussing investments, and you need to get hold of me. My details are on the screen. I'd like to thank you for watching, and good night.